care and referral management. So thanks again for joining us. We appreciate it. A couple of odds and ends, though, before we get started. The first is we are trying to keep everybody muted, but if you accidentally unmute yourself, can you mute yourself back, please? And we'll try to pay attention to that through the evening. If you do have questions, we do want you to put them in the chat box, and you can address them to one of the individuals, but better would be to address them to everyone so that other people can see the questions you have, because maybe they have the same question and it'll keep them from asking it as well. So we'd invite you throughout the evening, if you wish, to put questions in the chat box. We'll have some time at the end to try to answer those. And also, we did send out the Uber Eats vouchers to people. We hope you had a chance to use it. If you had problems with it, we apologize, but we hope it worked. If you did have some issues and you want to give us some feedback, we can't necessarily fix anything, but we'd like to know if there's issues that are going on that we need to know about as we try to use that modality in the future. All right, so let's get started. And so tonight we are going to talk about, I'm going to talk about the incentive plans, as I said, and we're going to cover both the specialty incentive plan and the primary care incentive plan. And we don't always do that, but we're doing that tonight so that everybody can see what everybody's having to be called on to do here in our work here at THN, because everybody's important and we need everybody to be successful at this. So I'm going to start out by first showing you the various plans that THN has for which we take shared risk or risk or shared savings. And so you can see that there's a host of Medicare and Medicare Advantage risk and shared savings plans. There's the Next Gen ACO, United Healthcare, Humana, HTA, Aetna, and Blue Medicare. The HTA HMO is the small CSNP program that we have, chronic needs special program that we have with HTA. We have some commercial risk and shared savings with Aetna, Blue Cross, United, a new entry into the market, Bright Health, and then Centivo, a Cone Health employee plan. And then we have a couple of quality plans for our primary care physicians, which are where we're just measured on quality. And these are pass-through quality programs for United and the larger part of HTA. So that's a lot of people. Somewhere in the neighborhood, I think current numbers, and Steve may give them more specifically later, around 200,000 people in risk and shared savings programs here at THN. So the first question as we think about our incentive plans is, what is it that we need to incent to be successful? Well, on the primary care side, we want people to be engaged. We need people to be involved, to understand what THN is doing so that their work will be consistent with the work that we're trying to do. We have quality gaps, and I've called these event-based quality gaps because these are things like colonoscopies, pap smears, did you get your hemoglobin A1C? What was your hemoglobin A1C? Things like that. And so these are important things that we have to use to be successful. And another set of quality measures, though, are patient experience measures, the CAHPS measures and others, and these are going to be increasingly important. And as I said earlier, Dave's going to touch on those. And of course, we all know the importance of proper diagnosis coding. Risk adjustment factor, man, we live and die by risk adjustment factor. So we really need that to be proper. And then one of the things that we're going to begin to do this year is try to incentivize our primary care physicians to really help coordinate care so that the cost of care comes in less than the revenue, because that's ultimately what needs to happen if we're going to make money in THN and share it with you as incentive payments. On the specialty side, we see engagement. So it's very similar to primary care. We need our providers to know what we're doing in THN so they can help us. We need to network fidelity. We need work together to be sure that the care that can be delivered in Greensboro, in Triad Healthcare Network, well, in not just Greensboro, but in our Cone Health system and in THN will remain in THN, because we know that it's higher quality and cheaper. We need to reduce unacceptable care variation. We want to reduce low value care. And specialists also have a role to play, some of them, in quality and RAF. So I want you to notice the interconnections here. So, there's quality and RAF on both sides here. This reducing of unacceptable care variation or reducing low value care will in fact lower the cost of care for that network, so that there's more that we can share again with our physicians. So what's the overall structure of the plan, the incentive plans? Well, Every plan, believe it or not, all of those plans that I showed you on the first slide, every one of them has an incentive plan. And we literally have to do an incentive plan for every contract because not every provider, not every physician is in THN for every contract. There are some exceptions. Our Kernodle colleagues, for instance, are not in our NextGen program because they are in the Duke NextGen program. And so we have to apply this quite specifically to each plan. So each plan then has to have a margin. We have to have the cost of care come in below the revenue. And if it does so, then we have a margin. And of course, we have to pay for the cost of THN as well. And then we have two funds called the baseline funds. And this is kind of the initial call on the resources that we have to share. If we do not use up all of the funds in those two funds, then it goes to what's called the remaining plan margin, and we go into what's called the full margin plans for both PCP and specialists. So the first thing I'm going to do is just walk through what are the basic components of the various PCP plans. So I'm not going to tell you every specific and every one of the 9 plans and all that, how that works, but I just want you to understand what the various components are. So we're going to walk through engagement, PCMH activities, quality and utilization, and cost of care and shared savings. So those are the 4 areas that all of the primary care funds, baseline or full margin, commercial or Medicare Advantage or Medicare, all fall into these 4 buckets. First, let's talk about engagement. For those of you present, you've now reached 25% of your engagement points for this year. So congratulations, we're only 3 weeks into the year, you're already 25% up on this. The engagement accounts for 20% of all of the baseline funds of the PCP incentive plans. So the way to fulfill points here are to attend town hall meetings or division meetings, and we will have multiple viewing opportunities for each meeting. I'll share that with you at the end of our meeting tonight, when your colleagues who might have missed tonight would have an opportunity to see this meeting and get credit for it. We have RAF academies, and these were multiple opportunities throughout the year. And our primary care doctors and other and their extenders are invited to attend RAF Academy and learn more about RAF and get credit for engagement. The Beacon is a very important newsletter that we have, and it's very important that everybody read this. We do require that you complete a short quiz at the end to get credit. I'm not going to tell you tonight whether you have to be right or wrong on the answers to that, but since I said that, you probably know. But we just need you to get through it, read through the topics and get to the quiz and at least answer that in order to get credit. And the quiz is open for 30 days for each of the beacons. And you'll see that if you read most of them, you'll get plenty of points. And then for our primary care offices over the last year, we've created what's called Elite Primary Care, which is a program where we have our practice performance specialists going in on a monthly basis. And then there's a quarterly basis with a quarterly meeting on with a THN medical director. And we are going to reward engagement points for attendance by the physicians at those meetings as well. So that's engagement. Let's now turn to PCMH activities. PCMH activities are only 3 things that we're measuring: the rate of completion of annual wellness visits, transitional care visits, and the percent of patients seen by the primary care provider in the office at least once. These are all critical things for the success of THN. Annual wellness visits are where most of the RAF is generated, and many of the quality metrics are closed, or at least attended to, maybe not closed right then, but at least attended to. Transitional care visits, critically important as people leave the hospital, that they get re-engaged with the appropriate physician, which most of the time is the primary care physician. There are, of course, times when that's most appropriately done by a specialist. And then we just need, even if patients refuse an annual wellness visit, we just need everybody to be seen by a provider in the office at least once a year. That service needs to be at least a 99213 or level 3 established office visit. You can see that these account for 20% of both the baseline fund and the 20% of the full margin fund. You don't have to score 100, so don't worry. Basically, you'll get almost full credit for each of these if you're in the 30 to 40% range of completion for transitional care visits, and a little bit higher for annual wellness visits. We will have more specific information coming out in the next few weeks, so you can see the actual numbers, but I didn't want to try to share those all with you tonight. Let's look at quality for a moment. Now you can see that quality is the vast majority of our incentive plan. It accounts for 80 to 100%. So that's a little hard to show on a graph. So that's actually 90%. So it's 80 to 100% of the commercial plans and 60% of all the MA plans. Notice that I didn't say Medicare. I didn't say NextGen. So we're going to come back to that in a minute. What are these measures? Well, we are all really familiar with these. These are the standard HEDIS metrics. Again, things kind of event-based metrics, colonoscopy, mammogram, depression screening, all that kind of stuff. Then there's a set of pharmacy metrics, which is medication adherence, how well are your patients using them, various statin use metrics, and then some CAP surveys, which for the first time, we are being measured by at least two plans for CAP survey on patient experience. I've done a rough representation of the weighting of these. So MA is very high on HEDIS and pharmacy and some on CAPS. Commercial, we have some event-based metrics. We only have one pharmacy metric on a commercial plan, and we don't have any patient experience surveys. Now, for everybody to just be aware of what's being asked of our primary care physicians, and I'm not going to expect you to read the next slide, but here are all the quality metrics that our primary care physicians are responsible for, with some assistance from specialists in select areas. 31 different event-based and pharmacy metrics. So it's a big ask for our primary care physicians. And you need to understand that the value to this is millions of dollars. Many of our plans have a quality-based targets in them, and the revenue goes up if our quality is better. And so these quality metrics literally mean millions of dollars for us. So that's why we emphasize them, and our primary care physicians work very hard to close all those. We're also going to have utilization metrics this year, and that's because of a change in NextGen. So you'll notice this is just for Medicare or NextGen baseline fund and the full margin fund, slight differences in the weighting, but this is only on the NextGen population. Now, in the past, NextGen has predominantly used event-based metrics, not quite the HEDIS metrics, but their own little set of event-based metrics. However, it was announced in December of this year that they are going to score ACOs on CAPS surveys and two measures of utilization. And those two measures are readmission rates as a percent of admissions, as well as the admission rate for patients with chronic disease. Now, we are going to be using readmission rate as a percent of admission, so we can match that with the NextGen program. It's a little harder for us to do admission rates for subsets of patients with chronic diseases. So we're just going to be incenting our primary care physicians on their ability for their population to control for admissions. And so really, if you think about it in the other terminology of ambulatory sensitive conditions, if we just do well at trying to keep people with chronic diseases and other ambulatory sensitive conditions out, then we will do well. So because of the effect of the Medicare changes, and because of our desire to begin to measure people on cost of care or shared savings, we are going to introduce to both the Medicare baseline fund and the Medicare and Medicare Advantage full margin funds a measurement of cost of care or shared savings. So basically, this measurement is going to be the cost of care for your practice's population of patients minus the risk-adjusted revenue. So this is all risk-adjusted, so the better you do for RAF, the more revenue there is for your patients, and the better off you'll do on this incentive. Again, if quality is better, then we raise the all the boats get raised as the water goes up, and so we will have additional revenue, and so better opportunity for some revenue here or incentive payments for our primary care physicians. For all of these things, we recognize that there is an important component of the social determinants of health. We will be frank with you and say that it has been difficult for us over the years to measure social determinants of health in a way that we could apply to our incentive plans. We are committed to do that. And the year that we can do it, we'll do it. That could be this year. We have some additional information and data on all of our patients, so we might be able to begin to approach this with using some social determinants of health. Medicare and CMS, in both the Medicare and the Medicaid space, have shown that quality metrics are better closed and cost of care is lower based on people with higher or lesser social determinants of health needs or higher socioeconomic status. So we want to recognize that in our incentive plans, and we will try to adjust for those if we can, but we cannot make a commitment on that at this time. So how is it that a primary care physician can be successful in the PCP incentive plans and THN? Well, first of all, engage. You're doing that tonight, so thanks, good start. Close quality gaps, same things we've been doing. Encourage medication adherence, and also probably new this year, understand really well what the CAP surveys are measuring, because some of these things are actually measuring your staff, not just you. So it's something that we need to socialize in your office about how patients' experience is in their as they go through their care. And so your staff is going to have an important impact on that as well. See your patients for annual wellness visits and transitional care management visits. Of course, always the proper diagnosis coding for RAF purposes, and coordinate care with your specialist colleagues. And so if people do that, I think we're going to have a good chance of for our PCPs to do well in our incentive plans. Let's turn and look at the specialist incentive plan for a minute. The specialist incentive plan has three buckets, if you will, or three categories: referrals and access, low value care, and engagement. Let me speak first for engagement. You can see here too, as with PCPs, it's 20%. And it's many of the same things: town halls, beacon readership. We have some videos you can watch. We'll have some specialist meetings, specialist division meetings through the year. And lo and behold, should you ever want to attend a RAF academy, perhaps you're in a specialty that has a lot of diagnoses that fall into RAF care, fall into the HCCs that give us RAF credit. We'll be happy for you to attend those if you wish. Just let us know if you'd like to attend, because you don't routinely get those invites. Let's go through the rest of this. First of all, referral management. 40% of our metrics is based on a use of the referral management system, and this will be based on measurement of the rate at which urgent referrals are seen within 7 days, and the rate at which appointments are made within 72 hours of receiving a referral. Now, that doesn't mean you're seeing the patient or their appointment is within 72 hours of receiving the referral. That just means the appointment has been made. We are aware that people leak out of our network because they do not hear from a specialist office when an appointment or a referral has been made. So this initial outreach is extremely important. And we also recognize the need for seeing people urgently. We also recognize that there are times when primary care physicians may not properly use urgent referrals. So we are wanting to ask our primary care physicians to be sure that only time you use an urgent referrals when it's really urgent. We actually, this didn't come out of the air. We think these are important things, but we actually surveyed our PCPs and asked them what do they need most to be successful. And the number one thing, as you can see from the response, was having the having the appointment made with a specialist and communicated to the patient within 72 hours of the referral. I'm not sure if all of our specialty colleagues understand this, but our primary care physician offices get calls from patients wondering when their appointment is going to be made. And eventually, sometimes that appointment goes somewhere else. So we want to be sure that that happens. And the urgent consult is also a very important thing for our primary care physicians. There are a couple other things you see here that are important: making sure that office visit or consult notes get back within 72 hours of the specialist visit. It's difficult for our primary care docs when they don't have the information they need to talk to the patient, just as we know it's hard for you, our specialty physicians, to talk to patients when you don't have the information from the primary care physician that you need as well. Our referral management system does have a dashboard, so you can kind of keep track of how you're doing. And so as this is rolled out, your managers will be able to see how you're doing at your practice, and we will get reports at the network level as well. And then as we look at the projects, most of the projects for 2021 are all supposed to be in, and we graded the last few today in the Physician Alternative Payment Committee. And so all those are in and rolling, but I do want to remind you that we do have some interim reports that are going to be required this year. These interim reports are one-page summaries of how's it going. Tell us if you're running into barriers. Tell us if you're being successful. We don't need to know great and long reporting here. It's simply a one-page report so that we make sure that you're working on these through the year. Now, So how to be successful in the specialty incentive plans? Again, engage with THN. Be sure your office is using the referral management system effectively. Do what you can to increase access for patients. It's really critical. I know everybody's working hard. I'm not doubting that, but we really need people to be able to see patients promptly. Care variation and low value care needs to be reduced, and that's a lot of our project work. And again, coordinating care with our primary care colleagues. So that's a summary overview of the THN incentive plans. As I said earlier, we will be having a more detailed report of this or summary of this published within the next few weeks. So you can look for that. We'll announce that through the Beacon so you can see all the numbers. But basically, this is an overview to let you understand what you need to be working on this year and for success. Finally, I want to make one other comment. We started last year a physician onboarding process. I just want to remind you that if you have new physicians that join your practice in 2021, we need them to participate in some onboarding. CHMG practice, the CHMG practice has a orientation session for their providers, and one of the THN leaders, administrator or clinical leaders, goes and makes a presentation, so that counts for them. And then we have through the year some THN 101 presentations, and so that needs to be attended. The THN 101 by our independent physicians, the CHMG one by our CHMG physicians. And then there's a couple of videos that are on THN Learn that you need to look at, and you can see what they are. And if you do those, then you are eligible in that year to participate in THN bonuses. Of course, you'd be eligible for the macro because you're a member of THN, but you would be eligible for THN bonuses or incentives because of your participation in our onboarding process. So I didn't read any of the chat questions as they went through. I knew that were some going through. We'll look at those and try to answer as many of those as we can at the end. But at this point, I'm going to turn it over to Steve Knorr.
Great, thanks, Jim. Let me pull up my slides here. All right, you guys see Jim, you see that okay?
I do.
Okay, perfect. All right, I've got a lot to cover, so I'm going to go relatively quickly. As Jim has suggested, if you have any questions, please submit them in the chat. I'm going to start by giving kind of really the current environment from a policy perspective very quickly. Obviously, we've got a few changes that have occurred here in the past couple months. Going to talk real briefly around our contracts. Jim just gave you a list of those contracts. I'll give you a little more context in terms of how many total lives we have. And we got some big decisions around some of our bigger plans like NextGen. Talk about a little bit about some trends we can expect to see in the Medicare Advantage space. Do a little celebrating of our FY20 financial performance as we do a year-end review. I want to talk quite quickly around COVID impact, and then lastly, kind of talk about where we're going. So let's start from a policy perspective. As most of you know, and hopefully most of you believe, we actually have a new president. President Biden was actually inaugurated yesterday, and he starts his session as presidency with a very narrowly divided Congress. As you know, right now the Senate could not be more evenly split. It is. The Democrats have control because of the tie-breaking vote with Vice President Harris. And as you see, a very narrow majority in the House. At the end of the day, they only have about 9 members. Believe it or not, there's actually 2 vacancies still outstanding. One, if you didn't know, was from Louisiana, a young 41-year-old guy died of COVID. So he has a vacancy that will certainly be replaced by a Republican. And there's one outstanding race that has yet to be decided in New York. A Republican is currently winning by several hundred votes, although the courts are involved and they're recounting some of the discarded votes. So what can we expect in this session? You're going to hear a lot about this word called reconciliation. And the reconciliation is it lets the Senate vote with the regular process, the cloture process, on measures that affect budget, such as spending, revenue, and debt spending. And so when we go through this list of things that most likely won't happen, when it comes to taxes, this is how it can most likely be done, is through the reconciliation. But again, we just talked about the narrow majorities. Senator Manchin from West Virginia, he's already really said he's against ending the filibuster, so we don't anticipate that to happen. This is Pelosi's her last tenure here as a House Speaker. And again, as you know, there's a yawning difference between the moderate progressive and from the lawmaker's perspective. So a lot of things that we can kind of scratch off the list most likely for this session: Medicare for all, a public option, major ACA reforms, although the Supreme Court heard arguments on the Affordable Care Act, as you know, right after the new Supreme Court justice was seated back in November. However, we don't anticipate any changes there, so we don't think there'll be any major reforms. Medicare drug pricing negotiations most likely will not occur. As I just mentioned, doubtful about the 60-vote filibuster passing, and any idea about court packing most certainly will not happen. Tax increases, again, you hear this idea about reconciliation. If it happens, that's how it will happen. So tax increases, I just put a maybe there. Again, number one priority, and if you are tracking the news, a lot of the executive orders that President Biden has signed both today and yesterday around COVID. I will certainly not read through all of these, but you will see a much more highly organized national approach and response to COVID in the coming weeks. And you can kind of see this is just a list of all the different things that he's seeking to have implemented to hopefully get a little better control of the pandemic. But the realities, I mean, hopefully we will get control of the pandemic, because then the realities start to set in, we imagine, a little bit later this year. And this is, you can see the graphs here over time from 2020 to 2050. And this is not really necessarily a new graph. It's just been expedited a little bit because of all the federal spending. And you kind of start seeing in 2038, basically, all of the federal revenue that comes in will be eaten up by net interest, Social Security, Medicaid, and Medicare. There will be no money left for any other spending. And so that obviously becomes a problem. So that will certainly be a focus starting this year. The Medicare Trust Fund is expected to be depleted as early as 2023. If you didn't know, Medicare Trust Fund is really the Part A spending, and that is actually funded by the money that's withheld from your checks. So the Medicare withholding in your checks, and as you match as an employer, that actually goes into the Medicare Trust Fund. It is expected by 2023 to actually expend more than it takes in, and then obviously that has to go to the general federal revenue to pay for more Medicare expenses. So again, what we expect is going to be major increase. I think the Republicans are going to care about debt. They've already, I think, started. So they're going to start caring about having debt now. That there's a Democrat in the office, and you're going to expect to see really increased focus on what we're going to value-based care. We're going to talk about that quite a bit, and some of the things that are very bipartisan, actually, and drug prices, in particular brand name drug prices. And also an increased push to value, and the CMS has promulgated quite a few voluntary programs here in the past. I think you're going to start seeing this out of the necessity to push more for these to be mandatory for hospitals and providers to participate. And again, there's really a recognition that, and we'll talk about this a little bit more, they call it the payer gold rush, that even though last year in 2020, and when we go over our financials, we certainly benefited from this, that the payers, even though the federal government has spent an enormous amount to fight this pandemic, what we are seeing is that the payers, the insurance companies, have really benefited from this and have generated record profits over that period of time. So there's certainly, that did not go unnoticed by the government, and they're most likely to take some actions that we'll talk about. But make no mistake about it, there are the things that will continue, for the reasons I just mentioned, is continue to move towards value-based. There's this kind of discouragement for the straight fee-for-service. And you're really going to start seeing much more, again, the private sector being expected to be the disruption. And that has both pros and cons. And so what you see here, this is a busy slide, but you're seeing this blurring line between, we used to say we got payers and we got providers. We got this new term now called payviders. And you're seeing, insurance companies that have become now pharmacies, and they're buying up providers. You know, a lot of people may not know this. United Healthcare, through its Optum arm, is the largest single employer of physicians in the country. They have over 53,000 physicians in their medical group. They're the largest physician group in the country. So you have this little blurring here between the payers and providers, and a lot of money pouring into the space with the expectation that there's going to be a lot of innovation, but it can also be a lot of disruption. And how we handle that is going to be certainly a challenge. The other piece that I want us to make sure we understand is a greater focus on primary care. In this value-based world, really it is understood that you really cannot be successful without primary care. The primary care physicians, as Jim just mentioned, really so much work is put on the primary care, but more importantly, all revenue flows through them. All the premium revenue, all the membership goes to them. And what you're seeing is that different companies now, and we have several in our own market now, like Aledade, Caravan Health is new in North Carolina, that are coming in and aligning with, in particular, independent practices to help enable them to perform better and take advantage of value-based care and get incentives and things like that. So you're seeing, whereas THN was really the only game in town for a lot of our primary care physicians, they have a lot more options now, and that option list is growing. So we always have to be very competitive and be very knowledgeable what the market's doing. On the right-hand side there, again, these are more, I would say, boutique or niche providers. They are focused, these particular providers are focused primarily just on Medicare Advantage and risk for Medicare and focusing on the chronic and fragile folks. So what are all the things? Again, I'm just kind of reiterating these things that although it's closely divided, there's a lot of bipartisan support for, again, the continued shift to private entities for taking risk. And that has some implications for us on our next-gen program, which I'll talk about. Again, moving away from fee-for-service to fee-for-value. Again, the private sector pushing that risk to them, letting them innovate. A lot more access to EHR and claims data, increasing the consumer access to cost and quality insights. And while doing that, really putting forth, I think, more, I say, effective quality and cost measurement, but you're also seeing a big focus on experience. You look at the star ratings and you have the experience, the member experience of being almost, I think, quadruple rated now. And certainly, although social determinants of health have been a buzzword now for the past couple of years, there's really an industry-wide focus on how to help address those social influencers of health. So again, I'll end with this section by saying, and by the way, I should have given credit, I really stole these from Premier. Premier is we belong to Premier through their Population Health Collaborative. So I want to give credit to Blair Childs, their policy guru. I basically stole these from him. But this was his last slide he shared. And what I felt good when I read this, because as we go through, when I go through the rest of my presentation, it's like these are all key things that we know and are certainly acting upon. You know, understanding the overall direction of the market, understanding the payment models. This is what THN does. This is what we do for you every single day. So aligning these payment models, you know, we just renegotiated all of our MA contracts, literally all of them, to get them more aligned with our payers and more aligned with us. The data and technology strategy, we are, as many of you know, we are getting ready to launch our Innovator our population health platform. I'm very excited about that. We talk about the RAF scoring all the time. I'm not going to talk about that tonight. But again, PCP strategy. So all of these things that he said, these are what should the members be doing. I felt really good about where we have been and where we're going. So I just wanted to kind of share that with you. So let's talk about contracts. Jim had provided the same list before. I put a little more context here with the membership. And you can kind of see, as he referenced before, we are managing just over about 200,000 lives, about 205,000 lives. Highlighted in yellow are two of our really new contracts for 2021. Humana MA PPO, we've had a PPO contract. It's been relatively small. The reason it's now jumped up in membership is the United Medicare Advantage to state retirees have now converted to Humana effective on January 1st. And so that is a new bucket of membership for us. We did not have a risk contract with United. We do now with Humana. The good news is we already know that we perform well with them and expect that to enhance our financial performance in 2021 and beyond. Right now, we don't have the exact numbers yet. We have to work through some attribution issues with Humana on the MA PPO side, but we're anticipating it to be about 8,000 lives. Bright Health, I'm hoping most of you know the name and participate with Bright Health. Bright Health is a company that offers insurance on the exchange, Obamacare, if you will. If you recall, this time last year, Blue Cross Blue Shield had entered into a separate agreement with Wake Baptist, in which they were the least expensive on the exchange, and they required all of our local members to change their doctors and go to Forsyth County. We didn't like that. We heard from the physicians, you didn't like that. So we ended up partnering very intentionally with someone to take them back. And so we identified Bright Health. They've been an excellent partner, and we appreciate all those that have participated and contracted with them in the network. They just went through their open enrollment from, I think, November through December, and they ended up getting just over 14,000 lives. We believe we'll get about 12,000 of those lives. And so not only did we get back, we lost about 8,000 Blue Cross to Wake Baptist last year. I think we got most of those back and then some. So I wanted to thank everybody. This is just a great proof point of collaboration between a payer and providers to make things work. So we're very excited about that new membership. We're doing shared savings right now. It's a new partner for us, but exciting about that partnership. So I want you to notice of our biggest chunk of lives here on the Medicare side is NextGen. And keep in mind, NextGen is our largest payer in terms of its traditional Medicare. So I want to spend a few minutes on that program because it's our largest in terms of Medicare, and also just talk to you about a couple changes and trends in that area. One, we performed well. In 2019, we earned about $9.2 million in savings. 2020 just ended. We won't know exactly how we've done it probably until May. We'll get our initial settlement with them. We're projecting between 9 and 12 million. A couple things to note. They did kind of change the rules in the middle of the year. Once it certainly appeared that under the old model, because certainly, especially in March, April, and May, when basically all the health systems were shut down and there was no elective procedures and things like that, they did not want there to be a huge savings generated. And so they changed the model, and they went from what they call a prospective benchmark to a retrospective regional trend. We will not know exactly what that regional trend is until after the end of the year. And so we'll let you know, but we're based on the working with our actuaries, we're kind of projecting that $9 to $12 million. But we did sign an amendment with them. Everyone was subject, whether you signed this amendment or not, everyone was subject to this trend change. But basically what the amendment did, it did cap our saving upside percent at 5%, but it also removed the cost of all inpatient care treatment for COVID. And I'll talk about that in a minute, and that ended up being significant. So it ended up going to save us between $5 and $7 million when it's all said and done. So that number could go up from where we're projecting, but that's a little on the conservative side right now. The other big thing, NextGen was supposed to end in 2020. This amendment basically extended the program through 2021. So that leaves us with some big decisions. So right now we are participating in NextGen for 2021. However, we're now faced with some decisions. Now, again, we don't know exactly what the new administration will do, but right now this program is expected to sunset at the end of this year, and we're going to have to evaluate what we're doing. And so there's some new models that have come out. One is called direct contracting. The other one's been out for some time called MSSP Enhanced. And so we're going to have to work with our actuaries to help us make this decision. The direct contracting model is new. It has three options. There's the global, the professional, and the geographic. The professional is more of a PCP-focused model, something we certainly need to be aware of. But for the global, it's similar to NextGen, that it is 100% at risk, but it also requires claims payment. So this is something new for us, and understanding exactly how that works. The geographic is also new, and that allows groups to take risk over, as the name would suggest, over a geographic area. That's not something we're necessarily interested into, but guess who is? That would be the payers. So we have several concerns about it because obviously if we're having to pay claims or track the CMS paying claims, I think there's some additional administrative requirements. Again, we don't get paid for those things. There's just several unknowns, especially how they do their benchmarking. There's some additional reserve requirements. And you can kind of see right now there's 51 groups that are signed up to start participating in April of this year. So the good news is you've got some folks out there on the bleeding edge. But if you look at the main folks, they're all folks that have a lot of money. Iora Health, Oak Street Health, which are both in Greensboro. The Oak Street Health went public last May, and they're now worth about $14 billion. And they basically have the same number of lives as THN does. If you're interested, that's kind of interesting. You got Village MD. You've probably heard some of these names, but a lot of these folks have basically quite a bit of funds to put towards these efforts. And what we're seeing is that payers are now stepping into this Medicare ACO space, which is somewhat disappointing because at CMS, from this beginning, it's really been provider-based. It's kind of been built from a provider up. And these new models are really inviting venture capital-backed companies, payers into the space. So in some ways, it kind of tarnishes what I would say these programs a little bit. But they're also starting to replicate CMS programs. One is called Primary Care First. It's a new model of compensation for primary care under the Medicare program. And it's only been offered in about 26 regions around the country as a pilot. But Humana had come out and said, we're going to implement this with all of our MA PCPs, well, not all of them, but those that meet certain criteria across the country starting in July. So again, just always having to make sure we understand what the market is doing. We're seeing United be very active in doing bundles with our orthopedic providers and other providers. So it's, again, seeing payers getting involved in this traditional Medicare space. And really the question is going to be, will smaller provider-based ACOs be forced to contract through payers? And I'm hoping not, but that's really a question that we'll certainly have to consider as we move forward. Now, our other big focuses are on Medicare Advantage. And that, as you can imagine, continues to increase in enrollment. We're up, as of the end of 2020, 39% of all Medicare beneficiaries are enrolled in Medicare Advantage. We're about the average here, about 40% in North Carolina. And we're about 57% in the Triad. And we'll see what the numbers are here, but mid-year in 2021, we could get up to close to 60% here in the Triad. It's going to be interesting to see. A couple of interesting things here. There's a process when Medicare Advantage plans, they have to file each year with Medicare. And they basically have to tell Medicare how much it's going to cost them to provide the services and what benefits they're going to provide. And typically, so what they call that is bid. And so they're telling the government, we think it's going to cost us this. And what's interesting is, on average, they're bidding about 87% of the county benchmark, the historic fee for service. But even with that trend, when you look at these other factors, Medicare Advantage continues to cost the government and taxpayers more than fee for service. So how can that be if they're bidding less than the fee for service? Because of two factors. One is coding. All this RAF stuff we talk about all the time, that generates additional revenue to the plans. And in 2019, the risk scores, because of those efforts by us and the plans, they were about 3% higher than the fee-for-service population, and it resulted in about $9 billion in additional payments. The other is because of the quality bonus, and that's what we talk about stars. And basically right now, if you are a 4-star plan or greater, you basically get between a 5 and 10% bonus in your revenue. And obviously, you can kind of see that burns, people don't necessarily like this, and when the MA is costing more. And so people are really starting to look at these things, especially, again, with those new realities that we showed that slide before. And then on top of that, of course, it's no secret, you can look at United Healthcare or Humana, it's all public knowledge. The gross margins on Medicare Advantage for insurance companies increase between July of 19 and July of 20 by 41%. So this certainly puts a target on MA's back. And again, the question being asked nationally is like, is Medicare Advantage worth it? Of course, there's always a need to compare apples to apples. As most of you know, Medicare Advantage does provide additional benefits beyond like dental and transportation and food beyond normal Medicare. But we are being told to expect changes in those areas under highest scrutiny. So we expect changes in the MA risk adjustment model and methodology, the benchmarks, and well as quality bonus. So I think the quality bonus is the one where they're feeling like, when they first implemented this, the idea was to really have plans separate each other. But what we're seeing is almost all the plans are 4-star. You know, it's not really, there is no differentiation there. And the question is, does it make sense to pay such a huge bonus for quality? And so we do anticipate there will be some changes there. So again, all these things we have to be aware of. And again, I think we're in a very good position. It's not, I share this to strike fear in anybody. It's just a recognition that, you know, it's good to know the rules, and it's also good to know how we're performing, and just expect that we're going to have to perform better than we are today. And we'll talk about our initiatives to make sure we can do that. So let's celebrate a little bit and look at our FY20. Just as a note, FY20, we run on the same financial year as Cone, so we run from October 1st through September. So our FY20 ended in October of last year. So we are now into our second quarter, actually, of FY21. So this is looking back at FY20. And again, I want to say we had a very good year. And we talk about the payer gold rush because of the pandemic. Guess what? We certainly benefited from that in 2020 from the pandemic in those months, the same as the payers. You can kind of see that we generated almost $76 million in 2020. It's a little skewed because we had such high surpluses in the first half of the year, and I'll explain that in a few minutes. You know, I would say you can kind of see here that what our revenue was in 18, about 45 million. That dipped a little in 19. Obviously, 76 million is by far our best revenue year ever. Although if I were to normalize it, it's probably closer to about 50, 52 million, and I'll talk about that in a minute. But when you look, well, let me do that here. Not to overwhelm you with all the numbers, this is just a breakdown of, because our contracts are mainly on calendar years, when we're booking revenue between our fiscal year, we have 2 years in it. And my point here was, you can kind of see for FY20, we had most of our revenue came in from our calendar year 19. We had a little came in from 20. We ended up booking a lot of extra revenue for 20 because of the amount of surpluses generated, you know, obviously during the pandemic. So that kind of bumped up our numbers there. At the end of the day, we had a fantastic year. We were able to contribute almost $19 million to the system to help them on a very challenging year from a hospital perspective. But we also, the physicians we generated 25 million, just over 25 million in total physician incentive that we put on our balance sheet. This is in addition to about the 4.5 or 4.2, 4.3 million we already had. So total, we actually go into FY21 in a very strong position from a physician incentive perspective. So just keep that in mind as Jim went through those incentive programs, those dollars, as you perform in those, the dollars that will be paid will come out of this fund, of the $30 million fund. Now, again, not saying we're going to pay out all of those dollars, because we still have to go through 21 and see how we perform that year. And we certainly have some challenges, as we've seen. But one big celebration, as most of you know, Cone has been an outstanding capital partner with us from the beginning. They have funded THN's expenses from the beginning. They fund all of our reserves that we're required to put up with the different insurance companies. You kind of see here, this is basically our net income for the first few years. This is the one we've had losses. You basically see this is how much we did not generate enough savings to cover our expenses. So through FY16, we generated almost $20 million in losses, in which Cone covered. And our current fund flow model had a model in which a portion of those dollars would go to repay Cone's investment, and then the other amounts would go for ACO participants. But you can kind of see, obviously, with the year that we had in FY20, we were able to pay that off, and so we have paid back Cone the $20 million they've invested. So currently, we're in the process. We'll talk about this in a minute about a new fund flow model and how best to share those savings going forward. But just a nod and an acknowledgement to this outstanding work of our physician community and our partners to make this happen. This is certainly a great team effort, and just want to take a minute to celebrate that. So, going from celebration back to warnings for us about COVID-19 impact. Overall, from a THN perspective, we've been relatively, I'd say, lucky, and doing air quotes right now. But you can kind of see this is through the first part of January, and obviously we can look at claims, we can see what's coming in. We can also see into Epic and not even have to wait for claims to get an idea about how many people have been admitted for COVID. So we've only had about 4,000 patients that had come in with claims, and we do anticipate that number to go up significantly as claims come in. But from an inpatient perspective, we've had about 1,000 people come in. I did want to share this with you because, again, this is one of those conspiracy theories. You hear that the hospitals get paid so much more to take care of COVID patients, are getting $20,000 bonuses. That's not true. You can see exactly on average that Cone is getting paid about $18,000. That is slightly more than their normal respiratory DRG, but certainly not a $20,000 bonus. And if you look at the length of stay, I think you'll find that most of the hospitals will say they're not making a lot of money on these patients. These patients can go and stay for a long period of time, but the average for us is about $18,000. What that translates, you can see, it means that we've incurred an extra about $18 million across all of our plans. The bulk of that being in NextGen. The bad news is we've had 289 people that have been in inpatient stays for COVID, and unfortunately, quite a high percentage of those have passed on. The only good news for us is, if you remember, we signed that amendment, and these costs will be excluded from our final settlement with CMS. When we signed the amendment, we only projected that cost to be about $3 million. So I think as we're looking wiser and wiser as each day passes around that cost, and so we anticipate that final number to be between 5 and 7 million. So I think we're feeling very good about signing the amendment that we did. Again, this is what is concerning, of course, is this trend. This is through the end of December, and these numbers have that angle has gone up significantly higher, almost to 45 degrees, obviously, as you know, into January. And so we're kind of starting out this calendar year in a precarious position of having very, very high admissions around COVID, and so we'll see where we are. So again, we're for FY21, so keep in mind we started in October. This is now our kind of fourth month, if you will, of our fiscal year. And I just point this out that obviously we already have booked a lot of those surpluses in 2020, and so we don't have those to really cushion us. And so FY21 is really going to be a key for us for our performance. So although we've got kind of $30 million sitting out there on the balance sheet for physician incentive, I think we're going to, obviously be very cautious as we look to see how we perform in now FY21, given these headwinds that we're facing. So, all right. Now, I want to end tonight on this initiative that we're calling Onward and Upward. And what I've stated is really just kind of this next stage transformation of THN. And where do we go from now? How do we meet these new challenges? I've had a stated goal. I would like us to have routinely, $80 to $100 million of revenue every year. Now, I know that doesn't seem like much of a jump, given that last year we had $76 million, but keep in mind that was a kind of a special year, if you will, in the sense that that's not going to be repeated. And if we were to normalize that and take out the benefit we received from the early days of COVID, like I said, our revenue is more in the $50 to $52 million range. So we're really talking about how do we double our revenue? We're talking about a path to it. And so we're really talking about two main focuses. One is around alignment. How can we align more closely with the health system and kind of changing cultures, challenging norms, getting really the system to think more around population health keeping people wealthy, keeping people healthy, excuse me, and really what I call reimagining margin, and really helping the system understand the significant value of keeping people well. That margin can be generated and the margin percentage can be much higher than having services performed in a bricks and mortar place. And we'll talk a little more about that. So alignment, working closer with the system, but also even more importantly is enablement. How do we perform better? You know, if it's going to get harder to generate savings, how do we continue to do that? So how do we become more consistent in our control of our medical expenses, and consistency in our quality scores, consistency in our RAF coding? How can we grow? How do we do these breakthrough results? How do we double our revenue in the next 3 to 5 years? And a lot of it's going to be, we're certainly looking at Innovator, as I mentioned, our population health platform to help do that. We're getting some help in these 2 areas. So Encore Health is a smaller boutique firm that we've really enjoyed working with, and we brought them in. We've got a executive strategic team working with Cone, really focused on this new funds flow and a margin reimagination and how that margin can be generated. So instead of really always focusing so much on that top line revenue, how many procedures are being done, how many people, how many heads and beds, really focusing on what is actually being generated on the bottom line. And can we enhance that bottom line by really keeping people well? And that's really kind of what we're focused on. And so Encore Health is helping do that. We should have some proposals to look at for our physicians on the finance committee and the operating committee here in the next 60 days. Enablement partner, as I mentioned, Innovator, PricewaterhouseCoopers, most of you have heard of. They actually have a partnership with Innovator, and they have a very deep bench of health care expertise. And I think once we bring up Innovator, we're going to look to have them work with us to really help leverage the new platform and how we can really maximize its effectiveness for us. So that's exciting. Again, this one, a couple THN strategies and initiatives. How do we do it? Most importantly is improving performance of our contracts. You know, I believe we've got $30+ million on the table that we can access if we improve our performance. And that's not to say we have bad performance. I'm just saying I know we can do better with greater infrastructure, with greater IT and analytics, and also with a lot of different initiatives. Again, expansion and growth. You know, the idea of what can we do, we need to focus on that PCP compensation model. We've got to not only make sure we maintain our current PCPs, that we don't lose membership, but we got to start thinking about really expanding our network of PCPs, and also, if we get really good at this, expanding outside the service area. And I think there's a great potential to do that. And you're seeing it with other providers on the state. And I think we can, as a provider-based model, I think we could be more effective in recruiting these PCPs to join us. Dual eligible conversion to D-SNP. Again, a lot of this is just being more cognizant of our chess pieces, if you will. These are folks, for example, on next gen that are dual eligible that may be better off switching over to D-SNP, which not only is it better from them from a benefits perspective, but it's also better from us from a financial perspective. I put a check mark here. It's actually by the state retiree. I mentioned that's something we worked on last year. We actually completed that. I think I signed that contract today. It's actually effective January 1st, believe it or not. But we do believe that conversion by itself should enhance our performance, our financial performance, anywhere between $7 and $12 million a year. Again, not guaranteed. We're kind of projecting what we think that impact will be, but that's nice, you know, if we're able to take that new bucket of Medicare Advantage lives and perform well. And project attribution is really being much more intentional in making sure that patients that are seeing our primary care physicians are on our lists. You know, what we see a lot is, especially for healthy patients, if they're not coming in to see the doctor, guess what? They don't get attributed to us. And so I think we're being much more intentional about identifying all patients in our PCP practices, working with our payer partners to make sure that these patients are on our lists. And so when you look at that, you can kind of see it's doubling our revenue, adding $40 or $50 million to the top line does seem somewhat overwhelming. But I think if you break it down into bite-sized pieces, it's definitely doable, and very excited. I'm very excited about the possibilities. So I think that's it. I think I did it within my time frame, Jim. I think I did. And so, again, please submit any questions in the chat function, and we'll make sure we can answer some of those here shortly. So I'm going to turn that back over to you, Jim.
All right. Thanks, Steve. And you did. I was very impressed. Way to go. So I'll turn it over to Dave now to talk about our next topic. There are several things he's going to chat with us about. Thanks.
Thank you, Jim. Thank you all for being here. I really appreciate the engagement. I can't believe we got almost 400 people, so thank you so much for that. I'm going to spend the next 15 minutes or so discussing network fidelity and patient experience of care, things that I'm very passionate about, and how improving referral management and access to care are really kind of key components. And I know this is not a new topic. This is so strategically important that it's critical that we reiterate and reinforce this. So 20 to 30% of the medical care that THN members get is provided by institutions and providers that are not part of our network. And of course, some of this is transplants and burns and rare cancers and all the things that you think about being done at academic medical centers. But the vast, vast majority of this is routine standard care that can be done in our community.
That Bruce Swords and Mary Jo Cagle have done and presented to us over these years.
Dave, sorry,
a lot of
Dave,
that,
Dave, it looks like you've got some sound problems. Could you work on that?
The things that I want to focus most on tonight are limited access.
Hey, Dave.
Dave?
Now,
Dave.
from a limited access standpoint, we do have some true shortages of specialists. There's no question that in some areas we could do with a lot more physicians. But a lot of this is really self-imposed inefficiencies. We have to get over this idea of really micromanaging our schedule, being inflexible, being limited by sort of our legacy compensation and incentive models that keep us from sending patients back to PCPs, by getting some of our patients that are seeing us to go and shift over. Hello?
Dave, I think you got a little sound issue, Dave.
I'm sorry, hold on a second.
All right, Dave, I think you'll be in good shape. We could hear most of it. It's just like you were pretty far down a tunnel. So
Okay. I apologize.
All right, DJ.
Hold on one second. Can you hear me now through this headset better?
Yeah, very, very much.
Okay, I really apologize. So I don't need to start over, I assume, or?
Correct. I think we could hear most of it. It was a little distant, but we could hear most of it. So I think we're okay.
All right. So in referring to limited access, again, there are a lot of things that we can do. I mean, most of the reasons that physicians limit their schedule, put barriers up, are very understandable. They're reasonable. They're rational, but they have unintended consequences. And when we hold a consult or a request for a referral because we want additional records or we want to assess that, the unintended consequences is that the patient often goes back to the PCP to look for alternatives or does something on their own. And so these are all the things that we have to work on. We have to consider this to be a priority with regard to our scheduling and all the things that we need to do. And this is true for how we look at compensation models. With regard to poor service, which is also an area that I wanted to discuss, this really isn't about, friendly voices and being, polite on the phone. While those components are really important, it's really trying to meet patients where they are and what they need. And we're going to find that more and more patients not only want and demand the ability to schedule their own appointments, to be able to continue to capitalize on virtual appointments once COVID is over. And so really, I implore people to think more and more importantly about access and these referrals and how we really meet patients and customers where they want to be. And it's a hard thing to do, especially when practices have 3 months of backlog, don't feel like there's really a need to do that. But those things can change and can change in a hurry. And we always have to consider where we are and how the competition is. And so these really need to be priorities. So really, why should we care about this? I mean, first and foremost, the cost of care. So care provided out of network, and I'll show some data on this, is generally higher cost care. And the 20 to 30% of leakage that occurs across our network is $200+ million in lost revenue to our docs, lost revenue to our healthcare system. The experience of care is clearly affected by this. The longer the wait, the longer patient satisfaction with care declines. And we're going to see where quality of care really and experience of care have really kind of merged together. And so longer wait times can result in avoidable complications. Patients may seek care in the emergency room several times before they see their specialist, and this care is often more fragmented. Most importantly, local care is outstanding care in our network. And so we have to really do everything we can to keep people within that network. And then something that's a little harder to quantitate. I mean, we really have to start thinking more about network cohesiveness and shared consequences. I think when Blue Cross Blue Shield came in and stole 8,000 of our patients, we can see where being a network, functioning as a network, and doing these things together are really critical. And, we share consequences of other people's decisions. If there's a particular specialty or division that is not very attentive to this and is problematic for patient access, these patients often seek care elsewhere, and then will continue those patterns once they've solved that problem, such that maybe a poor urology experience and not being able to get in locally might mean that their cardiology decision now is at Baptist as well. Now, one of the critical things is we talk a lot about Proficient Health. We talk a lot about our referral management system. But I would say that while technology is really important, and it's a critical part of being an enablement to have a referral system, it's really much more about culture and how we approach this, how we think collectively together. And so the same consultancy that's helped us with this upward and onward, PricewaterhouseCoopers, also came in and helped Cone and CHMG really assessing the whole referral and access sort of situation. And, their conclusions were not surprising to us that have lived and breathed this. And, as Steve Norris fond of saying, you can't be a prophet in your own land. So it was helpful that a consultancy came in and expressed some of these same ideas. But they found that there is definite demand out there that we're missing, and tens of thousands of lost patients. They estimated over $100 million in lost revenue within the Cone system simply because of leakage. And that providing really timely access to care for new patients was really a foundational requirement for realizing that benefit. And that while the referral management system and Proficient technology is really important, it can help as an enabler, it doesn't fix broken processes and misalignment. And so, this is really our best opportunity to kind of really unify THN, CHMG, and Cone Health. This is an area of real significant alignment. Now, we talk a lot about value in healthcare, and rightly, we talk most of the time about improving quality and reducing cost as key variables in this. But more and more, we need to consider service, and patient experience of care is really a key element in this. Of course, always considering appropriateness of care as well. And, when we think about what we need to incent to be successful, when I think about it from the specialty side, we've talked, and let me go ahead and get a pointer up here, a laser pointer. We talk a lot about network fidelity. And we continue to talk about that tonight. We've certainly talked in the past, especially when talking to specialists, around unacceptable care variation and low value care. When we talk about quality, a lot of this in the ACO and the Medicare Advantage space is prescribed by CMS. We think of lots of things that are important for quality. But at the end of the day, in the next gen, our $6 to $9 million is really determined, or has historically been determined, by HEDIS measures. Many of the quality things ultimately become these very specified, prescribed gap closures that the government has really decided is important for our quality. And that's that's made it more difficult to put quality from that perspective on the specialists. And now what we're seeing, and I'll show you in the next couple of slides, is that patient experience of care has taken a completely different importance in many of these. And now, rather than individual providers and practices, we need to think much more collaboratively. And really how we do from a network perspective is really going to be an important competency. And these CAPS surveys, a lot of them ask specifically around getting appointments and care, getting needed care, rating of the provider, communication between providers and care coordination. These are all the important things in a good, well-done referral management type of system and or culture, and also certainly around improving access. So this is just some examples of what I'm talking about. So in the next gen, historically, and I went back to 2019 because 2020 is such an unusual year and some changes with COVID, but historically, this is what quality looks like. And in 2019, this was $6 million on the line. And it was broken up into 25% quadrants. And so patient experience and CAP surveys was still an important component, but there was a lot around care coordination, which had to do with readmission and admission rates. And then 25% was on preventative health and things that we rely heavily on our PCPs for: breast cancer screening, colorectal screening, depression screening, fall risk, and then at-risk population, which is a lot of the typical HEDIS measures around diabetes control, et cetera. Now, fast forward to 2021, they've changed the quality metrics now to 50% being around CAP survey and 50% around these admission readmission rates. So in essence, we've lost this other part. Again, a marked increase in patient experience of care. In the Medicare Advantage STAR world that Steve Knorr just spoke about, stars are critically important. For Health Team Advantage, the difference between being 3.5 and 4 stars is about $15 million. Now, Medicare Advantage plans are held to a lot of different metrics, and many of them are administrative and are completely have nothing to do with providers. Providers have typically been measured and contribute to stars based on HEDIS, and the HEDIS ones are the diabetic, the gap closures, the colorectal screenings, et cetera, and some of the pharmacy metrics, which are a lot around medication adherence. And you can see CAPS had a smaller slice of that. Now, into measurement year 2021, so the year starting now, which actually turns out to be the 2023 star rating for Medicare Advantage plans, you can see that HEDIS has decreased and CAPS has doubled. So now we're talking about a fourfold change. And so for this year, Medicare Advantage plans are going to be much more reliant on their CAPS measures. And so there's going to be a sea change over the next couple of years. You already saw it in Next Gen. As these Medicare Advantage plans do risk contracts with us, they're going to be more interested in what's happening on the patient experience of care than they are necessarily with all these gap closures. We've already seen United add a patient experience care measure, but this is going to be a change that we're definitely going to see. And this is going to bring our whole network into the importance of our quality rather than individual HEDIS scores. And it's going to be an opportunity for all of us to contribute much more to the actual performance on the quality side. The other thing that's important is really finding some common ground and discussing some barriers that keep us from having the referral process and kind of the outcomes that we really look for. I can tell you, as we talk about incentives with our specialists and say, look, we really want to see you make appointments occur promptly within 72 hours. We want you to see urgent consults within a certain period of time. The pushback or comments we get are often, well, listen, we're not getting the information we need. We're not always getting the notes or the information that we need to make a referral, and we don't want to send the patient back after they pay their $50 copay. We're not always getting the information. And so likewise, on the primary care side, we're hearing that, sure, we send the patient, but we're not getting the note. Or more commonly, we get the note from the index admission, but the specialist says they're going to do X, Y, and Z, and we never get those follow-up reports. And so I think it's really important that we all take some time to think about the processes in our office. On the PCP side and on the specialist side both, we can't ask our least experienced, probably most underpaid workers in our practice to make these important decisions. This really is critical. And, help them understand what we need. On the PCP side, send that little note to the referral coordinator, especially if they're new, to say, look, send this note and the CT and the lab results. And on the specialty side, make sure that your medical assistant is sending back important notes. So these are really critical, important things to improve that coordination and make referrals more valuable. Now, as we talk about this leakage, there is a significant gap between considering this a priority and actually making it actionable and doing something about it. And so, in this particular survey, there were a lot of executives and people who run healthcare who said, look, this is really critical, but we're not really doing much about it. We're certainly not tracking it, and we don't understand what the implications are. And I can tell you we do. We absolutely know what we're losing, what the value is, and what the possibilities are with regard to revenue recapture and cost savings. But identifying the problem is the easy part. Making an impact is really where the challenge is. And these are the kind of things I see, and I don't expect people to be able to pick up everything on this slide, but we get reports and we have tables and we see who the payer is. We can look over time from 18 to 19 to 20 to see how we're doing. This particular table is around facilities and where admissions are and how many we're losing. And we can see there's general improvement. And we try to track them. So we try to put some cost savings or revenue recapture opportunity in this. You can see that very minimal changes in recapture, slight improvements in our ability to achieve some increased network fidelity mean tremendous increases in revenue and savings, especially given these modest results. And probably the area that we look the most at is leakage to academic medical centers. That's about 7% of the admissions in our network. And that in itself is probably a $15 million opportunity for Cone in the sense of admissions to recapture that revenue and the providers that provide services at the hospital, and potentially $5 to $6 million of savings for THN. And it's important. Well, how do we make this actionable? How do we do things to actually change behaviors? One of the ways I believe we can is through socialization, scorecards, holding people accountable. We've done some of this mostly on a positive side. We haven't, tried to point out places where we have more leakage, but that's something I think we have to do in the future. We started with some attaboys. We put tables like this in our beacon. We want to highlight practices that have performed quite well. This is independent practices that have had their patient panels have less than 15% leakage. It's obviously easier to do this in the center of Guilford County, right in Greensboro, than it is potentially in Kernersville or on the east side of Alamance. But we need to trend this. We need to see this. We need to provide people with data so that they can start to see, and again, understanding that what happens is really collectively affects all of us. On the specialty side and moving away from facilities, we really want to track and look at what happens on the Part B side. So for ambulatory care, for outpatient work, both in terms of E&M codes and also Part B spending, you can see that in 2020 for partial year data, about 22.5% of our outpatient work has leaked out of network. Now, on the good side, less than 20% of the patients actually leaked out. And so we had more costs than we did patients, again, indicating that work done within our network is more cost effective than that leaks out. Some specialties especially stood out in that regard. Ophthalmology, for example, 55% of the cost was out of network, but only about 40% of the patients were out of network, indicating again that within the ophthalmology division, cost-effective care is seen here within our network and not elsewhere. To give you some idea, in 2019, when we had a full, more normal year, 23.3% of that leaked. So 18 million, almost $20 million of opportunity. But again, we have to, having these numbers is one thing, and I've talked to specialists about this. We want to turn this data into insight. We've shared this with several different divisions. We have this data. We're happy to sit down with you. We can tell you where your leakage is going, who are the providers that are providing the competition, where in the specialty is this work going, from where, what zip codes, what counties, what primary care practice is it coming from, and also to some degree for what reason. And so these are things that can help you understand how you might come up with a plan of action that helps you recapture some of that work. The last thing I want to talk tonight a little bit about is e-consults and how this might also improve our ability to improve access. When when we sent out this survey to PCPs about what we can do to try to improve access and referrals, some of the things we've incorporated into the specialty incentive plan. But one of the other things that came up was the availability of telephone consults for care guidance or general questions. Difficult to set up within our network in terms of our busy specialists and how do we do that. And there are some solutions out there that we are currently vetting and actually discussing. And so one of these is Rubicon MD. Rubicon MD is already in place in many areas of the country. It's an e-consult service that really connects primary care to specialists. So this doesn't involve the patient. This gives a primary care physician the opportunity, generally in a very easy to use platform, one that we hope could be eventually integrated into our Innovacer workflow, gives them an ability to easily choose a specialist and ask a question, attach a EKG, attach a photo, and then very promptly, typically within the same day, get some guidance. And so it doesn't involve the patient, but it allows the PCP an opportunity to, number one, determine if a consult with a specialist is even necessary. If it is it really urgent or not? Maybe be able to solve the problem very easily without having the patient have to wait. Again, if we can eliminate some of those cases, I know that when I was in practice, 20% of the consults I saw as a practicing urologist probably weren't necessary, could easily be handled with a solution like this. And I suspect in most specialties, there are some work, and therefore the patients I'm seeing are really going to need specialty care. And so this can leverage both our local specialists as well as a national panel. So we always, in this sort of situation, it's really important to us, we would want to offer the ability to provide this service to our local specialists, but they would be under no obligation to do so. And so if they wanted to participate, they could. If they were unavailable and a PCP wanted to send a consult to a particular specialist, that consult could go to a local specialist. If one was not available or couldn't answer it timely, then it would transition to a national specialist. If our local specialists in certain areas are not interested, then the national panel would be able to do this. And so these most commonly, this involves these various 8 specialties. Dermatology and cardiology seem to be the most common use cases. There are a host of things. We'll share this deck with you. You can see that as a primary care physician, there are many questions that can be simply answered, and sometimes a little guidance is all that's necessary rather than a patient having to wait 3 weeks for a referral. And given that opportunity, patients are going to be very satisfied. There's going to be cost savings, and they're going to feel that care is better collaborated and coordinated. And I spent today a little bit of time speaking with the National Medical Director of Oak Street Health. They've been using Rubicon for some time now. He kind of walked me through how they've used it and what their overall feelings were. It was quite a positive endorsement, often very educational. He said the primary care providers often learn a lot and then don't have to continue to access the system. Better care plans for the patient. They've avoided unnecessary services, and overall, we're very pleased with this. This is not something that we've come to absolutely decide to adopt. We're in the process of negotiating what that fee schedule and cost might look like. We're in the process of vetting the possibility of a pilot study. But we certainly wanted to bring that to your attention, given the captive audience today, to tell you that this is a possibility and to look for potentially some more information about this. I think it would be a big value add. And with that, I'm finished, and I think we have a few minutes for questions. So let me stop sharing. And I apologize for that little technology problem earlier.
No problem. So you can go ahead and completely quit sharing there, Dave. Looks like we still got your screen.
Yep.
All right. Thanks, everybody. So we're going to go through the questions, but before I do so, don't anybody leave yet, because this is really important. We're not having a drawing, so that's not that important. But several of you are here by phone, which we appreciate, but we don't know who you are. Okay. So if you are on the phone and you're identified to us only by a phone number, we're not going to take roll or anything, but we need you to email us with your phone number. We've written all the phone numbers down, but we don't know who you are. So if you want to get credit for being here and you're on the phone only, you need to email us with your phone number. You could email jim.osborne. There's not a U in that. I'm not related to Ozzy. So jim.osborne@codehealth.com. or amy.robeson2@conehealth.com, or look at your invite to this meeting and just hit reply. But please, please, please let us know that you were here, because otherwise we won't know. So we're going to go through a few questions. First question was, do PAs and nurse practitioners count in the PCP incentives? So one of our hardest problems over the 10 years that we've been in the work in THN is trying to figure out how to handle our fine extenders who do a lot of work for us. Most importantly, I think, well, I shouldn't say that, but one of the important groups of our extenders are the extenders who actually work as primary care physicians. So with the the problem is that many plans do not recognize extenders as primary care physicians. NextGen does, HTA does, United Healthcare does not, Humana does not. So we have trouble when we get data from a plan understanding what it is that who's actually doing the work. So one of the things that we've been very careful to do in the last few weeks is in preparation for our Innovator implementation is we are now going to be doing some reattribution, if you will, from what the health plan says. And so for the first time when Innovator is up and running, we'll actually have some insight as to what's happening and what the contribution is of our extenders. Now, the work that our extenders do all gets rolled up under the physicians for whom they work, or in the practice for the practice for whom they work. So it's not like the work is lost. It's not like the revenue is lost, but it's really got mainly to do with where who gets the attribution, if you will. So just suffice it to say we're working on it, and that's where we are. Second question, does it have to be coded as a transitional care visit to count as a transitional care visit? The answer to that is yes. The reason for that is one of the important components of a transitional care visit is the initial contact. That is a contact with the patient within 2 business days of discharge. We think that's a critical part of the whole process of transitional care management. And oftentimes when that does not happen, the patient ends up back in the emergency room or just doesn't know where to turn if they need help. So please would recommend that you set up systems. We have a system called Patient Ping. If you're not on Epic, we have a system called Patient Ping that will let you know all of the patients that are discharged that are attributed to you in THN, and we can show you how to use that and get you set up. Third question, I noted some patients set up for the TOC visits in the Cone Clinic and not with me. Is there an algorithm about that? I am not aware of an algorithm, but I'm going to look into that. Thanks for that note. I will look into this because we don't need patients who have local physicians going to a transitional care clinic. That was my understanding when that was created, was for where people go who don't have physicians. So we will investigate that more. All right, it's confusing when THN does a TOC call. Does them contacting them take the place of our nurses needing to call and do the med rec? There's always some overlap here. THN is contracted with some health plans to do the care management, to do transitional care management calls. If THN didn't do it, then the health plan would be doing it. This is a point I understand completely, that this is confusing in my own practice. When our staff calls to do the med rec, the patient will often say, look, I've already done that, and they don't want to do it. All I can say is if we weren't doing it, the health plan would be doing it. Unfortunately, you cannot claim that as your transitional care management service if it's done centrally by THN. We are beginning to embed some care managers. If it's done by an embedded care manager in your office, that does count as your initial contact for the patient. There was a comment that very few of the metrics seem relevant to pediatrics. I should have printed a little bit higher. 7 of the 31 metrics, or 22%, are almost solely pediatric age. Well child visits in the first 15 months of life, well child visits in the 3rd to 6 years of life, childhood immunization status, adolescent immunization status, testing for children, appropriate testing for children with pharyngitis, and appropriate treatment for children with upper respiratory infection. So 7 of our 31 metrics are related to kids. So I do think there's an important aspect of here for our pediatricians, as well as things for our family physicians to attend to when they care for the little ones. As a specialist, when I get referrals, labs previous performed are an issue. KPN has been helpful. Is there anything more robust we can do? Not sure there's anything better than we can do than KPN right now. Glad to see that's helped a little bit. We'll take that under advisement and kind of wait and see. A comment about Bright Health for surgical specialists. Be sure that ASCs participate with them. And of course, that's a new plan, so not everybody might have been contracted, or maybe people choose not to contract. Who knows? But very important aspect of as people are doing their care. Another question about what's the timeline for getting more micro information, not just at a macro level. So Dave shared there at the end that if you have a specific ask or specific need, we'll be happy to investigate what we have. We think that innovation is going to be critical in our ability to deliver information to the physician at the physician level and the practice level. You've heard about the Rubicon specialists here. There were several comments here. We really want our local specialists to be participating on Rubicon. If they can, you actually get a payment for participating and that kind of thing. And so, Dave, you were going to say something? Dave.
No, I see that, like Dr. Sal said, disenfranchise our local specialists. Again, this doesn't take the place of, it's not an e-visit. We're not asking, Rubicon doesn't provide comprehensive care in any of these things. It's really just an opportunity for a PCP to engage over a quick question. We want our specialists locally to participate, absolutely. And sort of the nice thing here is that if a specialists are backed up and can't see a patient for a couple of weeks, and the PCP can talk to a Rubicon specialist, they might be able to keep that patient in the network because it's not urgent. We can keep them so they don't run off to Baptist and get an appointment the next day, and they can see the specialist. So it's only going to take care of problems that can easily be taken care of. I hope most specialists don't want to necessarily see patients that they don't have to see. And so in a patient that truly needs to see the specialist, it's still going to go to the local specialist. So I'm hoping between their ability to participate in this if they want to, seeing more important consultations and keeping people within the network, I would hope that it's a win-win for everyone.
Okay, very good. Thanks, Dave. So I may be losing track of some questions. If I do, I apologize for it. I do understand the issue with Randolph. We recognize that. We'd like to help as much as we can in helping be sure that care comes into the THN network. What about Centera Health and Cone? Oh man, you got another hour or two? So the short answer right now is THN's continuing to do what it's been doing. And so I don't think we'll see any immediate changes from what our mission is. At the operating committee last week, Mr. Aiken and Dr. Cagle joined us, and Dr. Cagle gave a really quite emotional set of comments that she is committed to value and the journey that we're on, and THN is the leader in that for the health system. So I think we will continue to be extremely important for them. So a question about Bright Health. Karen Bradish, our contracting person, would be the person to contact within Cone. So within THN. So feel free to reach out to your practice performance specialist for a contact for Karen. And then Dr. Shaw sent me a private message that I won't have time to answer tonight. I'll get back with you about that later. All right, so we've gone a few minutes over. Listen, I appreciate everybody's participation. We had outstanding attendance tonight. Thank you so much. However, there are probably some of your colleagues who were not able to attend for various reasons. We have recorded this session tonight, and we're going to give people 2 opportunities to see this, the recording for credit. And at those meetings, there will be a THN medical director, or there will be 2 THN medical directors to answer questions at the end. You may tell your colleagues that the first one will be on January 27th at 6:30 a.m. That's 6:30 a.m. for people who want to do it from 6:30 to 8. And another one on February 2nd at 6 p.m. So if your colleagues did not make it, feel free to pass that information. We will also put information in the beacon about that in emails as well. don't promise them a Uber voucher. Okay, they're not getting an Uber voucher. Okay, you got to be here in person to get the Uber voucher. Okay, that's just that's a new THN rule. Okay, and then for our various meetings in the future, we will have another town hall involving all of our providers in late August. For our PCPs, we are planning a PCP division meeting in the second week of May and the first week of October. So look forward to those things. So again, thank you for your attendance tonight. Thank you for your thoughtful questions and your interest. Feel free to email any of us at THN if you have additional questions. Have a great evening and take care. Bye-bye.